closer to
Hey, John.
Yes, sir.
This is not, I don't know if you want me to say this during the meeting. I think embedded is EM, not IM. Looking at the minutes.
Spelling. I don't know. I didn't look at the minutes. Oh, on the minutes?
Yeah.
Like inshore,
I'm looking-
inshore?
Yeah, I'm looking at page 3, I think it is, or page 4. The last page.
Embedded, you're right.
Okay.
Okay.
Why don't you go and bring that up during the minutes?
Okay.
Or I might. Well, if I forget, you can remind me.
Okay.
It's all for Clancy, no.
But you know, if you Google it, it's pretty clear and dry. You get off of Fairview 38, phone, make a left, and you're right there. As long as you read the number.
Unless you want to do it.
You're the director. You can do whatever you I can do it all, but you can
You do it all then.
Okay.
So what I mean is don't skip just right to this, make sure you say something about like
Of course. Okay. I mean, I really wrote all this. I would start with that.
Perfect.
And then bounce to that. And then bounce to that.
Great.
But that's kind of,
Sounds good.
that's the flow. But I'm going to.
should be up there. This is second in the
Did anybody say they weren't coming?
Hello. Hey, how are you? Morning. Good morning. I'm not all by myself. I'm not all by myself here today. Okay. Good.
Now you're going on? I know. Maybe say you're going in my office. That's fine. That's a lot. How are you doing?
Okay.
Me too. Me too.
Do we have any of the advisory members? Do we have any of the advisory members on the phone line with us this morning?
Yes, it's Larry Matthias. I apologize, but I'm on the phone today.
Oh, that's good, Larry, because we need you for a forum.
Okay.
All right.
Assume that my silence is an assent.
If we, let us know if for some reason you have to go off the line. I think Athena's going to mute the phone.
No, can't.
Nah, we'll leave it open.
No, we'll have to leave it open.
Okay.
But if you have to leave the line, either let us know or text John or myself so that we can see that, and then we'll have to make adjustments to it, to the,
Okay, I will, but I will mute this because there's always background noise.
yeah, I appreciate that, thank you. All right, it appears that we have a quorum this morning for the Plan Certification and Management Advisory Committee. This is the posted time and place of the meeting. So I will call it to order this morning. We're teleconferencing between the Health Insurance Exchange Office here in Carson City and Southern Nevada Child and Adolescent Services campus in Las Vegas. So with that, I'll ask, participants that are calling in this morning to please mute your phone so we don't get background noise. And then I will go, I think that's the only announcement that we have right now. With that, then I'll ask Mr. Hager to do the roll call.
Dr. Ahern appears to be absent. Dr. Jackson appears to be absent. Mr. Finch appears to be absent. Mr. Mathias,
Here.
you're on your phone. Ms. Mayville appears to be absent. Dr. Roberts
Here.
is here in Las Vegas. Mr. Woodley
Here.
here in Carson City. Vice Chair Dr. Klein
Here.
is in Las Vegas, and Chair Campbell
Here.
in Carson City. We have a quorum.
All right, thank you. First item on the agenda is the approval of minutes of the advisory committee from our meeting on February 20. Oh, I'm sorry. Thank you so much, John. First item on the agenda is public comment. I'll start here in Carson City.
Thank you, Chairwoman Smith-Campbell. For the record, Chris Ferrari on behalf of DaVita. We submitted a letter late yesterday to the subcommittee to discuss specifically the network adequacy standards pertaining to dialysis. We noticed in the draft network adequacy standards there is a reference to nephrology on page 7, but I wanted to make sure that the subcommittee was aware of the difference from a nephrology perspective. A nephrologist typically sees a dialysis patient on a once-per-month basis, whereas the dialysis treatment itself occurs typically 3 times per week. Because of the debilitating nature of dialysis, people can be fatigued and have a difficult time getting back and forth. The request that we're making in this letter is that dialysis be included under the emergent accessibility standards as it pertains to maximum travel distance or time, with the 30 minutes, 60 an hour, 75 or 1.5 hour time limitations to ensure that folks can get back and forth from their homes to their dialysis treatment. From a cost perspective to the exchange, this is also critical, as if somebody misses one of these life-sustaining treatments, oftentimes they require emergency services through transport and hospital, which can create additional expense burden to the exchange. Again, we've submitted a letter, and we've also been on record to this effect before this group in October of 2012, and we appreciate your consideration. Thank you.
Thank you, Mr. Ferrari.
And just so that the committee and public is aware, the comments from Mr. Ferrara are on the webpage for the concert meeting.
All right, let's jump down to Las Vegas, and then we'll come back here to Carson. Any public comment in Las Vegas?
See none.
Thank you.
We have two members have just shown up.
All right.
And
Tell us who has joined the meeting, please.
Vicki Mayville, do I need to push this?
Yeah. Vicki Mayville.
Hi, Wayne Finch.
Thank you.
and we have really good sound, so we heard you just no problem.
Okay.
All right. Again, I was just going to, no public comment in Las Vegas?
None.
Okay. Back here in Carson City, please.
Good morning. For the record, my name is Lisa Caparota with Nevada Advocates for Planned Parenthood Affiliates. We have also provided testimony to you on the issue of network adequacy and essential community providers in the past. I did also late last night provide my comments, and they will be online, I think. I don't think they're on at the moment, but I believe you do have a copy. We particularly have 2 specific concerns that we would like you to consider as you move forward with these interim adequacy standards. The first is on page 1 when it's discussing how a carrier would demonstrate that they had a sufficient number and geographic distribution of essential community providers. The recommended standards say that a sufficient number would be at least 20% of the available essential community providers, or at least 10%. I don't know if that's an option for you to choose from, or I read it over about 5 or 6 times, and I can't see the difference in those two phrases, so I'm not really clear which the standard is, or if that's a place where you're making the decision. However, we feel very strongly that 10 or 20% of the essential community providers in any geographic area would not ensure reasonable and timely access to a broad range of providers. When you look at the list of essential community providers that is available from the data set, there are only 100 in Nevada. A large number of them are tribal health centers, which would not be available to everyone in the community. Several of them are single community health nurses who certainly are part of the essential community provider network, but we'll only be able to see a limited number of folks. In the Washoe County region, Renown Hospital is listed as an essential community provider, and certainly for some of these services, they definitely would qualify, but wouldn't be able to access private care there. So if a carrier only contracted with 10 or even 20%, that would be too big providers, and it really wouldn't provide a broad range of services, access to a broad range of services for members of the community. So we're asking that you consider a standard that's at the top of the second page of my comments. Sufficient number and geographic distribution is defined as contracting with all essential community providers in a geographic area who are willing to contract with the carrier under reasonable terms and conditions. So basically, all willing providers, essential community providers, would need to be included in these contracts with carriers to make sure that people had access to the full range of services that are represented in the essential community providers list. And the second topic that we have raised several times, and particularly when we consider the rural communities, there are a lot of very sensitive health services that people have some concerns about seeing a health provider in a rural community, particularly say a community health nurse. For example, we see a lot of sexually transmitted infections, folks for testing and treatment of STDs, STIs. People, understandably, in small communities have concerns about possibly going to the one healthcare provider in a rural community. So we also would ask that you consider a standard in the network adequacy standard that says, in recognition of the sensitivity surrounding certain health services, each carrier shall cover out-of-network services, out-of-network sensitive services at no additional cost. And each qualified health plan will allow clients to go to the healthcare provider of their choice for sensitive services without prejudice and without requiring pre-authorization. And these are standards that our health centers for the exchange in California has adopted. I don't know if this is the exact language, but it's a similar concept, and it's been successful there. So we hope you will consider those two additions to these standards.
Ms. Capretta, just a question for you. We just got this, and I'm able to read through it all the way, but do you have a definition of what sensitive services are?
I didn't provide one here. I think we can probably find one if you were interested in us looking for one. I can provide you some additional information.
Well, if the committee or the board wishes to adopt any part of this, I think it would give more clarity to what you're asking for. Do we have any public comment on the telephone? Okay, with that, we'll close public comment. For the record, Dr. Linda Ash Jackson has joined the meeting. All right, let's move on to agenda item number 3, the approval of the minutes from February 25th. Are there any additions, edits, or comments on those minutes?
Madam Chair, we have one correction on page 4 in the motion. Just a misspelling of the word embedded. It should be EM instead of IM for both, or 3 instances of that.
Any other corrections or edits?
the minutes be approved as amended.
Can we have a motion from Dr. Jackson?
I'll second.
And Mr. Woodley seconds the motion. All in favor?
Aye.
Any opposed? Motion carries then. Agenda item number 4, discussion regarding amending the plan certification recommendation number 8 that was approved by the board on December 13th, which deals with network adequacy standards. So who's making the presentation? Mr. Haycock?
So for the record, Damon Haycock, Finance and Research Officer for the Exchange. Good morning, Madam Chair and members of the committee. Today my report will discuss network adequacy standards as they are presented from the Division of Insurance. Currently, network adequacy standards are only applied to HMOs, and they are under the authority of the Health Division at the Department of Health and Human Services. The Division of Insurance has a bill in the session right now, Assembly Bill 425, their omnibus bill, that shifts that authority from the Health Division to the Division of Insurance to establish network adequacy standards statewide. On December 13th, as was mentioned by Madam Chair Campbell, that there was a recommendation that the Exchange follow the network adequacy standards established by the state, and that the Exchange the board recommend to the state that they include essential community providers as well as telemedicine as an option for those network standards. So the Exchange currently has authority under federal regulation to determine network adequacy standards for the Exchange marketplace. And because of the Assembly Bill 425 and the time factor of going through all the regulations thereafter, if it gets approved, the Division of Insurance will most likely not be able to apply those network adequacy standards to the Exchange until the end of summer. However, binders are due at the beginning of summer to the Division of Insurance for plan certification, and therefore we run into a conundrum of not having the regulations at the state to approve those standards for that plan certification, and we would not be able to have qualified health plans that met network adequacy standards on the Exchange unless the Exchange adopts their own standards on an interim basis. So the Division of Insurance has provided the attached network adequacy standards, and I'm going to go over them. I don't want to say briefly, but I'm not going to go over them completely unless you have specific questions. But understand that these standards were developed with Exchange staff. They were developed with carriers. They were developed with providers, as well as higher education. And so they have been vetted so far with those various groups. And with that, I'm going to go ahead and move to the attachment. Unless you have something to add, Mr. Hager? Oh, yeah, and these network adequacy standards, this attachment is directly provided to the Exchange from the Division of Insurance. So in the first section on page 1, it goes over the general basis for this process, that provider directories will be updated online no less than every 90 days and filed with the Division of Insurance and SURF. Section 2 discusses the network access plan template in SURF and how to receive an attestation form for those attestations on that network adequacy component. Section 3 discusses how to refer by the primary care provider for covered services from a provider or facility within reasonable proximity. Section 4 discusses the limits to the amount of travel required to obtain coverage benefits. Section 5 goes into disclosing to all covered persons the limitations or restrictions to access of participating providers. Section 6 discusses the American Indians and Native Alaskans who are covered persons that have access to the Indian Health Service. Section 7 then addresses the essential community providers, which does follow the recommendation from the board on December 13th. And I want to attempt to clarify one of the issues from the public comment. The 20% of available essential community providers, and then it goes on to talk about 10% of essential community providers. This was taken directly out of the document that was provided by the federally facilitated exchange for their network adequacy. And it is our interpretation that you either have 20% of the ECPs in the area, or you have 10% of the available ECPs in the area, plus all of that narrative justification language thereafter. So look at it as 20 without the justification, or 10 with that justification, and that's our interpretation. But this is taken directly from the federally facilitated exchange. Section 8 talks about adequacy of choice for providers, that they can reference any reasonable criteria used by any carrier, provider to covered person ratios by specialty, or geographic accessibility, volume of technological and specialty services, etc. And Section 9 talks about provider availability and accessibility standards for a multitude of different categories. Starts off with primary care providers and OBGYN accessibility standards. And all of these standards for all of these categories discuss a maximum travel and distance or time function. And they're broken out by urban counties, rural counties, and frontier counties. This was done because of our difficult geographical situation here in Nevada. A lot of the network adequacy standards that were developed for the federally facilitated exchange or for other states out east or in the Midwest don't have the same difficulties of our frontier counties. I think Mr. Hagers is fond to say that I think Rhode Island is smaller than the distance between some of our counties.
Oh yeah, Maryland is smaller in square mileage than 2 of our counties, and they have 20 counties just in the state of Maryland. So yeah, we've got some very unique challenges here.
Very unique. There is no best practice model for anyone to adopt for network adequacy standards for the state of Nevada, because we are so difficult to provide. Before I go on to the next section, I want to make sure everyone understands that at the end of each of these categories, there is a section for to justify if you can't meet these requirements. And I want to bring your attention to the last sentence that is in every one of those. Telemedicine may be utilized in order to provide accessible care to meet the above network adequacy ratios and travel standards. So that's the other part of the board's recommendations. So the Division of Insurance did take those into consideration and apply both recommendations to the network adequacy standards you have today. Moves on page 4 to the urgent accessibility standards, again with maximum travel distance or time. The emergent accessibility standards on page 5. The mental health and substance abuse accessibility standards on page 6. Specialty providers accessibility standards on page 7. And again, I want to bring back to the attention that telemedicine may be utilized in order to provide accessible care. In Section 10, it talks about the provider network adequacy goals, offering adequate number of contracted and participating providers, offer a network that will vary from one geographic area or county, or excuse me, the number of network providers will vary from one geographic area or county to another, and so on. Compliance with distance standards, minimum distance standards for PPO insureds will be achieved if 50% of the population of the area is enrolled within the distance standards of the providers with whom the carrier contracts, and that the carrier shall provide a wide choice of accessible physicians, facilities, and ancillary providers. Finally, in Section 11, it talks about provider network requirements. Must be adequate in number, include at least one community hospital, comply with the ECP requirement, use best efforts to include 50% of the PCPs with active staff privileges or hospital admitting privileges or agreements of the contracted community hospital, include with each county or multi-county region enough primary care and specialty care physicians, and a provider directory must be available for publication online and to potential enrollees in hard copy upon request. All of these meet the requirements that are outlined in the federal regulations for the exchange, and these are the network adequacy standards that the Division of Insurance is recommending that the exchange adopt, because these are those standards that they plan on adopting as they go through the regulatory process after their bill, Assembly Bill 425, is approved. And hopefully that this will be the standards statewide, both in the exchange and off the exchange, by the Division of Insurance, hopefully by late summer, early fall.
If I could just add a couple items to that. So first of all, we will correct the misspelling of Story County. And then second of all, these are the recommendations of the Division of Insurance that, as Mr. Haycock said, that they have been vetted with various groups. However, in any regulatory process, there is a public hearing process, and these could change during that process at the Division of Insurance. So we hope that the recommendations that the committee recommends and the board approves are as similar as possible to that end product, but there may be some slight differences. So we'll work with the DOI to make sure that if there are differences, we'll work with both the Division of Insurance and the carriers to make sure that the carriers will comply with whatever statewide item is adopted. It may be necessary to have a separate effective date for qualified health plans for these statewide adopted items if those differences are too great. The other side of that is carriers are generally pretty flexible at making their networks work, and it doesn't. They do not necessarily have to refile a plan to make some minor modifications to networks. If they're major modifications, then it might be something that needs to be a delayed implementation on their side. So again, what Mr. Aycock said is correct. These are from the Division of Insurance. This is what they plan on going through the public vetting process. Additionally, when we get to the regulatory process, so we hope that the standards are as close to final as possible when the board approves these standards.
I'm going to start opening it up for discussion then. I don't know if you want to go through section by section or...
This is Ron Klein. Can I ask just more of a broader question?
Sure.
Rather than section by section? My main concern in what I've heard is the telemedicine aspect of it. And, I think telemedicine is coming and it certainly has a place. My concern is that a carrier might use that telemedicine exception to not contract with somebody who's available. So I'm just picking an example out of the hat. You might have 2 or 3 neurologists in a county, in a rural county, and the carrier would choose not to contract with any of those 3 neurologists, but instead would say, you can consult with our neurologist here in Clark County or up in Washoe. And, certainly there's a place for telemedicine if there are no alternative choices. But if there are people in a geographic area who are available and the carrier chooses not to contract and rather to sort of just use a telemedicine as an excuse not to, then that's a concern to me. And I don't know how that can be addressed.
This is Linda Ash Jackson for the record. What I can tell you is I wish there were 3 neurologists in a rural county.
Sure.
I can't remember.
For
I can't
example.
remember if there's a neurologist in any of the rural counties right now. But to be honest with you, I think that one of the points that the carriers made with the division was, if in fact you open it up to levels of alternatives, there are physicians in these rural counties who travel there twice a month who will not contract with the carriers because they're the only game in town and can basically charge whatever they feel like for a procedure to take place. I think that we need to make a distinction between what telemedicine can provide in terms of diagnosis and consultation versus the urgency of a procedural process. From my perspective, and in my role as the medical director of a health plan, I have these cross my desk on a daily basis. That I had one yesterday that a non-contracted provider was going to do a screening colonoscopy at Humboldt General, and I knew as I signed that I was signing up for an $8,000 screening colonoscopy based on what I was going to have to pay the hospital, a critical access hospital, the anesthesiologist, and the non-contracted gastroenterologist. I think in certain situations, I think the division wants to provide guidance around what should be provided locally, but by the same token, doesn't want to force the carriers into economic situations that would make an ability to provide coverage in that area even more prohibitive, and you might not have anybody sign up for the rurals in your exchange. So I think this is a reasonable balance, and I'm pretty sure that that's why they wrote it that way. But by the same token, they did not want to have to say, in order to comply, the carriers have to get together, which they can't do, and sponsor an ENT person in Ely. You know, I think that's one of the concerns that the division had.
How do you find the middle ground? I mean, I see your point, and I think you probably see my point. And so how do you, what is the middle ground in the sense of, you know, what we're really trying to say is telemedicine is an acceptable alternative if you can't sign a reasonable contract with a physician who's already in the area.
And then again, if you go down the road and you define reasonable, aren't you getting into restraint of trade issues? So, you know, I think they're trying to come down somewhere in the middle, and that's why all of these criteria are subject to review of network adequacy, and they're going. I'm guessing that they're going to compare the networks of all the different the carriers to try to make a determination if a service is available, why might United cover it and my hometown would not? So I think that there's enough discretion in here, particularly that you have to get exceptions through the commissioner that might provide this policy to be reasonable. I'm going to turn to my other local health plan compatriot.
Steve Woodley for the record. I completely agree with Dr. Dash Jackson in her perspective with respect to the carriers. We certainly don't go out with the intention to not contract with rural providers. The outreach is made. If the terms are acceptable and there's a willingness on the part of the provider, we welcome them to the panel. So I don't have anything further to add. I completely concur with her perspective.
I may miss something. Is there, the Division of Insurance has to review the network for all the carriers? I may have missed that in the paperwork.
That's part of the binder.
Certification.
Okay.
And the certification of the QHP, right?
Okay.
So.
Okay.
I think, Dr. Klein, then what I'm hearing is if there are enough people that are applying for QHPs, there'll be enough competition that the Commissioner of Insurance can look and see that one carrier is not accessing enough of the providers where others of them are adequately getting providers. So there's some oversight to that.
Okay. I didn't realize about that oversight process, so that's fine. I understand now. Thank you.
So I move that these recommendations be accepted based on the potential date issues related to the submission deadlines and the legislative actions that might need to be put in place.
I second the motion. Steve will leave the record.
Okay, and then I'm going to open it up for discussion just to clarify your motion there.
Okay.
Mr. Hager, weigh in on this. If we adopt these, they're not subject to any legislation going through. We will have to, if legislation is approved for it to be moved to the Division of Insurance, and after they adopt regulations, those regulations will supersede ours at some point in time, and we may have to work through the mechanics of any differences that come about. Is that correct?
For the record, John Hager, sort of. It's kind of complicated because we have a federal regulation that says the exchange can adopt network adequacy standards. Then there will be a state law regulation that says that the commissioner will adopt statewide network adequacy standards. So I think what you have is both standards will be in place for whatever qualified health plans at that point, unless there's a delay in the implementation statewide for qualified health plans. So what you would have then is two standards that, if they are different, the carriers would have to comply with the more stringent of the two standards in those particular areas. It's not our intention to have two standards, and we certainly want to take a look at this and see where the differences are when the final item from the Division of Insurance comes out in the late summer or the fall, and determine if we need to change things on our end. Of course, the issue will be that the carriers will have already submitted their plans under our standards. Now, the reason that we've asked the Division of Insurance to provide these to us is because we hope that these are as close as possible to what they end up approving. So I don't think it's a matter of theirs will trump ours. I think they will both be combined at that point unless there's a delayed implementation for qualified health plans that the Division of Insurance approves.
And I would guess, Linda Ash Jackson, I would guess that the only modification that they would put in place, because there was such diligent work on this, would be if they found that there was a potential glitch or glitches within the implementation of the process, where they might come back and say, well, this is a concern. And they can always do a look back, or you could ask for a yearly review, if that was better, but easier.
Do you have any questions from Las Vegas or discussion on the motion?
None? No.
Mr. Hager has made a suggestion that before we take the vote, that maybe we open this up again for public comment. So do we have public comment?
For the record,
It's very quick.
Yeah, we have public comment here, yes. The public comment, Las Vegas?
for the record, this is Linda Bull with Liberty Dental Plan. Is the board's recommendation to apply these for the standalone dental plans as well? Or will you be adding language that's specific to the dental plans?
For the record, John Hager, we definitely overlooked dental when we provided these. We actually thought about that in the last couple of days, going, oh, we didn't do anything for dental. This certainly would not really work well for the dental plans. It's a completely separate type of product. So we do need to come up with some type of measurement for dental plans. And I don't think that the legislation contemplates that the Division of Insurance would oversee network adequacy for dental plans, just for health plans. So that would be something that we'd have to bring back to either the committee or the board. I imagine it would be much simpler than this. You're talking basically for the most part, two types of providers, and I think you've got your primary care, your typical dentist, and the ones that do your major work. So we are willing to take suggestions if you want to send those to us for dental network adequacy. We have not had a chance to look over and come up with a formula for dental network adequacy.
Mr. Hager, I thought that we, in one of our earlier meetings, made a recommendation based on the good work that was done by Damon to say that you weren't going to put specific criteria in place for year one on dental because you're going to work through that. So I'm guessing that we already dealt with that, and that I think you took it to the general board so that you may be off the hook.
That sounds like a great idea.
I remember going through that discussion because I used that document back at work to go through what had to be satisfied for the remainder of the information.
So let's put the dental one on hold for just a second while we do a little bit of research and we're going to continue with some of the other comments. I don't know if she was done.
More public comment here in Las Vegas?
I was going to bounce it back and forth between the two because
Okay.
we're going to get a lot of comment here today. So, Ms. Foley, would you want to?
Thank you, Madam Chair. Helen Foley, representing Delta Dental, and that was our concern, whether or not you would address it soon or leave it for another year. The other thing is just a minor typographical. White Pines County, there's an S on the end of White Pine. You should probably change it in addition to the Story County.
That sounds great.
There's only one pine tree.
There's that one white pine.
All right, back to Las Vegas.
Go ahead.
Okay, I'm Randall Downey with, excuse me, the Nevada Alliance for Retired Americans.
You know, we can't hear you. We
Come
cannot.
closer. Come here. This is.
Sorry about that. Randall Downey, Nevada Alliance for Retired Americans. First, I'd like to say I appreciate the work you've done here this morning. and I anticipate good votes. I hope you seriously consider the suggestions made by Ms. Caparata. I'd also like to add, I don't see it in the standards, and it may be part of the regulations, and I've not seen anything that tells me they currently exist or need yet to be developed. But the point is, what if a major practice group under one of the carriers jumps ship mid-contract year and moves to a different carrier? How then do you protect the rights of the enrollees into those plans? Like you need to hire co-pays, loss of your direct care practitioner. Do you automatically disqualify the QHP if that were to occur because they no longer meet the adequacy standards? Perhaps this is something that should be considered. Case in point, and the date escapes me, it was either late 2010 or 2011. Under the Medicare program, a major practice group exited, broke their contract with one of the major carriers and moved to a different carrier. This directly affected several hundred, if not 1,000, enrollees in the original plan. CMS at that point in time, through the regional office out of San Francisco, stepped in to make sure that those rights were protected and take any possible action that needed to be taken. So this could occur, and I'm not certain if it's the responsibility of the exchange, the Division of Insurance, or currently the Health Division. They may have regulations on how to handle such a situation. If not, I encourage you to put those standards into effect. Thank you.
Back here to Carson City.
Thank you, Chris Ferrari. On behalf of the Dental Association, I just wanted to make the subcommittee aware that we've reached out to the American Dental Association to determine if there have been any network adequacy standards set for dentistry anywhere that they're aware of in the country, so we will report back to this as soon as we have some information on that topic. Thank you.
Anyone else down in Las Vegas?
Just nobody, but just myself. I'm sorry if this is an appropriate time. I was going to say the same thing. I forgot as we were going through. We had two, I think, relevant public comments in terms of dialysis services being applicable to the network adequacy standards in terms of geography, and Ms. Caparata's statement about sensitive medical issues. And I think we discussed, though I don't think we discussed those two things. So are we going to address those in some way, and how are we going to approach that?
Well, I think that, and we've got our Deputy Attorney General here with us, Sarah Bradley, and maybe you can help us with this. The purpose of public comment is not for the board to take action at that moment in time on it, but to provide more information or things to the committee or the board as they're developing.
Well, you haven't voted yet, so I mean, certainly your hearing comment might affect the vote that you take or any further discussion you have after you close public comment up. Because if you want, you could certainly close public comment and you could have another board discussion before you vote, if that would be helpful. But
So we can address. I mean, I understand public comment is to hopefully educate us on it, and hopefully that translates into action if it's appropriate. So is it not appropriate to address those within our conversation?
Yes, it absolutely is. Why don't we finish taking the public comment that we've got, Dr. Klein? We're still within, we've got a motion and a second on the floor with discussion still ongoing for the committee members. So does that sound reasonable to you?
Yeah, I just want to make sure we didn't go by that before we addressed it.
Okay, thank you. We have more public comment here. In Carson?
Joan Hall, Nevada Rural Hospital Partners. I certainly appreciate the addition of telemedicine, excuse me, in the standards. Still have some concerns looking at the rural adequacy, have these discussions, the distance for Ely in White Pine County, for Nye County residents, especially in Tonopah, Battle Mountain. They are farther than 3 hours from an urban center. They might be closer to another rural that perhaps has some of these, especially specialty services. But looking at some of the specialty services, none of us have them. There aren't neurologists. We would love one neurologist, let alone four. We made it. Also,
All right, bad
looking
example.
at trying to increase the telemedicine panel. It has been a challenge for us. We continue to work with that. We hope that you would consider, I think, under primary care and OB accessibility. In many of the rurals, we don't have pediatricians and we don't have OB family practice docs do that. So I hope that that's inclusive in that you consider that.
My understanding after discussions with the division, that they do understand that, and that in the rurals, that OB/GYN services are provided by primary care providers.
And let's assume in there. Do you want to know how to get
And then just some of the mental health.
Been on low for a couple hours.
Okay, excuse me, for those participants on the phone, can you please mute? We're getting some background conversations. Go ahead, please.
Mental health and substance abuse accessibility, the hours here for telemedicine, the mental health and substance abuse accessibility is 24/7. So what we kind of compromised with our northern telemedicine system is that we would keep those patients with mental health or substance abuse issues in the ER until 8 o'clock or 9 o'clock in the morning when the school medicine cycle for them. So that 1.5 hours. So I know you know of our issues, so I just want to make sure that we recognize that and that our community members do have access to insurance exchange and we recognize issues with ours. We appreciate that you've been open to us and listening to our issues. Thank you.
I'm Elisa Cafarata with Nevada Advocates for Planned Parenthood affiliates. I just wanted to follow up and let you know that I certainly understand this is sort of a phased process where we're trying to do two things at once on different time schedules. So we wanted to commit that we will also be in contact with the Division of Insurance and discuss our recommendations and concerns with them, and so that hopefully, and I understand they have a regulatory process that's got certain deadlines and they need to go through 60 and 30-day notices and all that, but we will commit to try and moving our recommendations along both tracks so that we end up in the same place. We don't end up with different standards that need to be negotiated as we move forward.
Do we have anyone on the phone that would like to use public comment? All right, Dr. Klein, anyone else down there in Las Vegas?
See none.
Anyone else here in Carson? Okay, I'm going to close public comment and then we'll bring back the discussion for the committee members. Dr. Klein, do you want to get started?
Sure. I think both points that were made about dialysis and sensitive medical issues are relevant and important. And I just wanted us to speak to that. I understand Ms. Cafarata's point about sensitive issues. I have some concerns about letting somebody just go to anybody at the cost of the insurance company, because then you wind up in unreasonable situations sometimes. But I guess we need to find some middle ground that addresses that. I also am unaware of dialysis services in the rural areas in terms of if we were to include dialysis under the same mileage and travel time standards, what effect would that have in terms of what's, considering the present situation? So I guess I think we need to address them, but I need to be better educated.
Linda Ash Jackson, I can't really educate you specifically to dialysis, hemodialysis, and travel times, but there certainly are alternatives for patients to be supervised by dialysis centers and do home dialysis a number of different ways, either home hemodialysis or peritoneal dialysis, and we see that very often in some of the rural communities where it's very difficult for patients to get in, that they will be on peritoneal dialysis, and they are trained and they have follow-up oversight from the central facility. I think that what my concern is that if we don't pass these minimum standards today, you won't get binders completed. So perhaps we could go back and ask the division to look at potential ancillary services availability and coming out with standards for that would not delay the binder from being submitted for a qualified plan if they felt it was necessary.
All right, so what I think I'm hearing is you still stand with your motion to adopt these minimum standards, but bring to the attention of the Division of
Insurance that there may be other services outside these that require addressing.
And Steve Woodley for the record, and I would concur with that. The 2 points I would make is generally to the extent that public comment could be provided sooner so that we could review the content and what has been presented instead of on the day of would be helpful. And the second thing is with respect to Ms. Cavarotti's comment about sensitivity surrounding certain health services. We would need, from a carrier perspective, you're talking about an out-of-network reimbursement rate. So I think the carriers, before wanting to commit or be committed to something along those lines, would want to know the definition of that. So some more details should be forthcoming, and then it would be a matter of interpretation with respect to, because now you're getting into payment processes the carriers are being held to. And I would be uncomfortable, weighing in on that as well. So I would agree with Dr. Linda Ash Jackson that if the recommendation go out, as stated, the first and the second, with the minimum requirements that are in the draft emergency regulation, adequate time could be adopted to allow the DOI to flesh out some of the additional, and then the recommendation will go to the full board anyway. So there could be a change at that level before it is necessarily completely, closed out. That would be my thought.
And this is Ron Klein. I agree. I mean, I think I'm fine with adopting the motion. I'll vote for the motion. But as you point out, the motion is not adopted until the board adopts it. I don't know, John, when our next board meeting is sometime in May, I presume. So perhaps there would be those 2 or 3 week period of time when we can address this issue in some appropriate way that everybody's happy with.
For the record, John Hager, so we put on the agenda for next week's Wednesday legislative update agenda these network adequacy standards, not specifically these ones, but the agenda item to discuss them at that meeting so that we could provide them to the carriers on the May 1st carrier onboarding meeting. And we realize this is a little bit rushed. It has been difficult to come up with the standards that we've got here at this point. And again, these have been through a process already. A couple of comments. There was the discussion from the rural hospitals about the difficulties that they have in complying with some of these, or not complying, but having providers available to meet some of these rules. And at the end of each section, it says every consideration, including established community patterns of care, will be given by the commissioner to the relative availability of healthcare providers or facilities in the geographic area when determining if the carrier meets the above established network adequacy provider standards. So that is in there. Back to the dental piece, it was the item that was delayed was the accreditation for 1 year. The network adequacy standards were not, and the standard approved by the board was that a QHP issuer must ensure that the provider network of each of its QHPs meets the following standards, includes essential community providers, complies with any network adequacy standards established by the exchange, and is consistent with the network adequacy provisions of the Public Health Services Act. So we do need to look at those and come up with some basic recommendations for that. And for those ones, like I said, that would be done completely at the exchange. I don't believe that the AB 425 contemplates network adequacy for dental plans, so those would not be done at the Division of Insurance that we have here.
But we can use the setup or the model on this to adopt.
Yes.
Mileage and time.
And then I also have to defend those that provided public comment at the last minute. We had these on Friday and we missed getting them posted on Friday, so they were posted on Monday, so they didn't have a lot of time to look at them either, so it's my fault.
Well, with 3 days noticing, a lot of times we need to develop public comment.
Madam Chairman, I would just like to make one more comment around benefits. I would say that it would be a mistake to include benefit determination within the network adequacy standards. The Division of Insurance and Nevada statutes have ample definitions of how plans are to be constructed and how benefits are supposed to be administered in terms of disadvantaging or advantaging patients. And I know that they're looking at that again. So to me, that's a regulatory process that's already in place as plans are filed and viewed. And we already have the federal legislation that mandates preventive care that is added to probably on a semi-annual basis. So from my perspective, what's in the network and how it's administered are two different things, because the state already has that protection for the potential population. I just want to say.
This is Larry Mathias. I think piggybacking on that, what we don't have much experience in Nevada or in the country is really looking at network adequacy or inadequacy as that becomes a limitation on what the benefits actually turn out to be. So I support the motion. I think that this allows for trying to develop standards, probably over time, more specific than what we're doing at this point, based on the experience of people, whether or not they're adequate to the needs of the population that's being served by each of the plans. And so I think that this will feed into the Division of Insurance's evaluation of the rules going forward, and will also be something for the Exchange Board to look at over time as you will get complaints or concerns from specific patients who have had access problems. So I think this is a good first step, but it is only a first step.
Any other comments from committee members? All right, then I'm going to call for the vote on this. All in favor of the motion?
Aye. Aye.
Any opposed? All right, the motion carries. And then, Mr. Hager, then you can just pass these public comments on to the Division of Insurance for their consideration when they start to adopt regulations.
Yes.
Okay. All right, I think we've covered everything under item number 4.
Yes.
All right. Agenda item number 5, possible actions for other future meetings. We will have to bring back dental.
Apparently.
Are there any other issues that the committee needs to deal with in future meeting? Okay. Any comments from any of the committee members on dates or times? Is this something that we need to do rather quickly? Yes. Dental? So
Yeah,
expect another meeting in a couple of weeks then?
Yeah, the binders are due on, I June 7th. So yes, it'll have to be done very quickly. Now, my guess is that the dental networks, the dental insurance companies that are going to be providing plans will be able to comply with the network adequacy standards that we develop. Again, it's not our intent to develop standards that are so strict that carriers can't meet it. It's simply a minimum standard to make sure that they aren't providing, charging a premium and then they can't comply, they can't provide a service. So I don't expect that it'll be a major shift for them, but we do need to make sure that is set and they can move on that. As a government entity, we need to provide this information as quickly as possible so that what business is like is just make a decision, don't care what it is, make a decision and we'll deal with it. And so, not that we want to make a rush decision or a bad decision, but we do need to make a decision.
Why don't we plan that we have this discussion at this committee so that we can adopt those standards at the May 9th meeting? I know that's probably short turnaround, but I think the carriers need that.
Absolutely. So we will work on getting a committee meeting together in the next couple of weeks.
Let me ask our Deputy Attorney General, would there be an issue if we had that committee meeting the morning of May 9th? If we properly,
As long as it's noticed, you can have a committee meeting.
in the morning, and then adopt the recommendations at the full board later in the afternoon? I mean, I don't know if that helps staff to keep everything on one day instead of trying to do a couple different days. Just think about that as an option.
Well, now that we have our conference room here, it's a lot easier.
Yeah. Okay, so we'll wait for some updates from you on possible dates and times. All right, I'll go ahead and open it up again for public comment before we adjourn. Are there any persons in Las Vegas wish to speak?
See none.
Thank you. How about here in Carson City? How about on the telephone? All right, I'll close public comment. I want to thank everyone for their time and effort and preparation today. Thank you, staff, for developing this with POI. And with that, we'll adjourn the meeting. Thank you, everyone.
Relative to panelists. What is our next? What are we still discussing? Dental network?
Dental network.
Network standards?
I had thought,
They may have some, I know they've been talking about that. So they are like
The last that I looked at, FFE said their network adequacy standards start with
There's no reason that you can't.
Well, see, that's what I thought you said, Margaret,
And that's it. And then, yeah, but I don't think that. But we're not even accredited by it. And we're not even accredited, and we're not asking to be accredited for a year.
And I thought, because I remember thinking that I was upset that you hadn't put those in place, that they weren't gonna have to comply. That's why I thought,
No, I think it would,